Welcome, everyone. I'm Michele McDonald-Werstuck, Chair of the Primary Healthcare Action Group, and welcome to our webinar series brought to you by our Dietitians of Canada, Family Health Team, RD Network, our Action Group, as well as AFTO on malnutrition, specifically looking at detecting and correcting malnutrition in family practice and creating collaborative approaches to do so. So this first slide gives you a brief introduction into the call-in numbers for those of you who are looking for access codes, as well as gives you instructions in terms of lines will remain muted for most of the session until we get to the question and answer period, just to minimize some of the background noise. And any written questions or comments you have, please send them forward, and you can submit them online at any time using the questions panel on the right-hand side of your screen. And if you do wish to speak, there is a little option of a raised hand there. If you click on it, it'll let us know that you would like to make a comment, and we can make sure you have a chance to share your information. So I'd like to thank everyone for joining us for this webinar series. We have an hour together, and hopefully after this session you'll have an introduction to some of the literature behind malnutrition in seniors and why this is an important population that we want to spend some time looking at, as well as some of the tools we'd love to share with you that you might take back to your teams to have conversations about this population and how it might work in your practice in terms of embedding screening into usual practice. So moving along then, we have, oh, there we go. Everyone sees the slides? Great. Okay, so the time is right to do this because we're working closely with our LHINs and with the restructuring with the government to start to take a closer look at the populations that we're serving, as well as the populations we're currently not serving. And malnutrition in seniors is considered an urgent condition, coming with very high costs to both the individual, increasing risk of falls, increasing risks of effect on quality of life, as well as morbidity and mortality. And when we look at some of the economical literature, quite a high cost to the healthcare system, with in fact 2 billion of the 25 billion hospital budget accounting going for seniors malnutrition or malnourished seniors in our healthcare system. So a very costly expense for our healthcare system that really we could be looking at and making a difference to. We've put in a slide, Dennis, are the slides working there? I'm hoping the slides are, and all of you have the handout anyway. But we have added a slide on a little YouTube video that you might want to use with your teams. It's a 1-minute video. We're not going to show it today, but it's very short and to the point and really emphasizes the issue of we are missing this population in family practice, but also in hospital settings and elsewhere. So malnutrition is often missed or overlooked, and this clearly starts to identify that gap. When we start to look at some of the literature quite clearly shows that this is very prevalent. So in Canada, we have about 1 out of 3 seniors at nutritional risk, according to StatsCan. Other countries say prevalence rate of malnutrition varies between 20 to 50% of the populations. We know it has a negative effect on quality of life, and we've added some slides in here to give you some literature, and we have a lot more references if you're interested in collecting this. Part of today will be to give you a malnutrition toolkit that we've created through the action group that will give you some of these key references and articles as well as screening tools. We know malnutrition also increases risk of falls in our seniors, and we know that a malnourished senior is 3 times more likely to fall than a well-nourished senior. When we start to look at our hospital literature, there are a recent Pan-Canada study that looked at 18 acute care hospitals across Canada. When you start to screen on admission and discharge, we're finding that about 1 out of 2 of our seniors are going into hospital with malnutrition. So that means it's happening in the community. And when we look at that population while in the hospital, we find that they don't do well. They tend to worsen while they're there, they tend to stay longer. They also tend to be the folks that get readmitted 30 days later. And one of the things we are advocating for is how can we work with our hospital colleagues to make sure that malnutrition is identified at discharge, so in family practice we can pick it up and carry on with the nutrition care plan that hopefully have been started in the hospital. But the good news is that there is a therapy that makes a difference, and that, when it comes to malnutrition, is food. So food really is medicine in the case of malnutrition, and there's plenty of resources and reference material out there showing that nutrition support can optimize nutritional intake and improve functional status, correct the nutritional deficiencies, promote weight gain and restore some of the lean muscle mass loss, as well as hopefully prevent further decline and manage the existing comorbidities that many of the patients we see come with. So when we look at this food as medicine concept, this is just another infographic we've created through the action group showing some of the impact on outcome measures of nutrition therapy on some of the common comorbidities we see in family practice. But also we need to now think about malnutrition as one of those issues to add to that. And when we look at food as medicine and we look at cost savings, it really is a substantial cost savings. So every dollar spent on nutrition intervention saves the healthcare system between $5 and $99 by reducing hospitalizations, medication costs, and freeing up physician time. So when we also look at the literature, you know, is there a therapy that works, and what about a team-based approach? There is quite strong evidence out there that a team-based approach dramatically improves patient outcomes. And the American database shows quite a bit of literature, as well as the UK, as well as Denmark and Australia. So in terms of countries, Canada, we're a little bit behind the rest of the gang identifying this population. But the good news is the literature is showing that if we start to screen these folks and come up with team-based care plans, we can make a difference. Next slide there, Dennis. So one of the things that brought this to our attention was, as dietitians in primary care, we have about 500 of us from family health teams and CHCs, we started to look at some of the data. We did a recent workforce survey, and we found that we were getting very few referrals for malnutrition in primary care, and that's code 263. Despite the evidence showing quite a high prevalence in the population, and despite the evidence showing that nutrition support and team-based care can make a difference, we weren't seeing those folks. And I'd like you to take a minute and think about your own practice. You know, over the past year, how many referrals have you received for malnutrition? As if you're a colleague that's joining us, how many referrals have you made for malnutrition? Again, when we start to look back over the data, we often find that this is one of those missing populations, that the literature shows we have good support to be focusing on, but we haven't currently been doing that. So really it's time to take a closer look at the senior population in terms of malnutrition, and really to build collaborative approaches into our practice so that we can screen our seniors for nutritional risk, chart those risk factors, refer to appropriate care providers, and that really will require a team approach, because we all know malnutrition is quite a complex issue and will really require all of our expertise. And E stands for education, and that means educating our patients, our family members, our team members, and then of course evaluating the outcomes. You know, does this work, and does this make a change on patient outcomes and healthcare outcomes? And then really creating a network. We need this network of team members within our family health teams and CHCs, but also with our community partners, because this is a very large issue and it's going to take a very comprehensive approach to make a difference. And for that reason, our Dietitians of Canada Primary Healthcare Action Group has been starting to create some infographics that hopefully you can use in your settings to have discussions with your colleagues and with your directors to really shed some light on this underserviced population that currently we're not seeing a lot of, but yet the literature shows we should be. And we've been really advocating for embedding screening tools into your practice and creating this collaborative approach to managing malnutrition in our seniors. So what we've been up to, we've been trying to raise awareness of the prevalence of malnutrition in the seniors and really advocating for the use of validated screening tools and a collaborative approach. And so many dietitians and other colleagues around the province are starting to zero in on ways we can be keeping our seniors well and keep them out of the hospital. We've been educating our teams about malnutrition, setting up screening programs to detect issues early, counseling our patients to improve their nutritional health and prevent future falls and hospitalization, going out to folks who can't come in to see us, doing home visits, and also trying to set up those communication channels between home care and hospital so that we can facilitate care coordination across our settings. And we started back in May at our RD Research Day in last May 2016, where we brought together about 50 dietitians from family health teams and CHCs to really start to looking at our outcomes and how can we reach the most vulnerable in our practice. We also had our quality improvement folks with us to really help us see how can we change our EMRs and systems so this is easier for us in practice. And we're going to have Amy and Denis be sharing some of those great tools that they've developed with you or for you. So at the research day, the question became, who do we try to focus on first? Do we focus on the elderly or the well elderly and keeping them well nourished and out of the hospitals? Or do we focus on the most vulnerable? And so many of us thought this would be a great opportunity to look at existing clinic processes and link screening with these processes. So when patients are already coming in with another chronic disease, coming into our clinics, such as these newly formed memory clinics that many of us have, the diabetes clinics, the INR clinics, these are opportunities for us to see, to embed screening into that usual practice and see if we can pick up any folks who might be at risk. The other population is our newly discharged seniors. For many of us, the ministry has now mandated that those seniors recently discharged are assessed relatively quickly after discharge, and this is another opportunity to be thinking about ways to embed screening into that practice so we can detect issues early and hopefully make an impact on outcomes as the literature predicts we can. And the third population is those that require home visits. So after you figure out which population should I try to focus on first, and this will be very different depending on your organization, the question is which screening tool to use. And there's many out there. We have chosen 3 that we wanted to introduce to you because these tend to align with the Canadian Malnutrition Task Force, which I would encourage all of you to access, which has a wonderful depository of resources and evidence and literature. And the 2 tools that they recommend are the Canadian Nutrition Screening Tool, the one in the middle there, that basically is a short 2-item tool asking about unintentional weight loss over the past 6 months and low appetite. And then there's Screen, which is the 14-item screening tool, Seniors in the Community, Risk Evaluation for Eating and Nutrition. So both of these are Canadian made by Dr. Heather Keller, one of our champions in malnutrition and senior health. And again, we're trying to align with the Malnutrition Task Force to use tools that have been validated for our communities. The third one there is the Mini Nutritional Assessment short form that has some literature actually showing it's very effective for seniors with cognitive issues. So again, if we're going to be screening our seniors in our memory clinics where they have mild cognitive impairment or Alzheimer's, that may be the more appropriate screening tool to use. It's shorter, it's clinician administered, and for many reasons, sometimes our colleagues prefer those shorter tools. So again, these tools are adaptable to the groups that you would like to use them with for screening. So the next slide helps explain that a little bit. So Denis, if you can click on the arrows, it starts to show, where you might want to use these tools depending on your goals. So who are you trying to screen? Are you trying to screen upstream, where you might be looking at changes in eating behaviors, such as the Screen 2 tool will do, starts to look at changes in intake and food groups, etc., as well as food access? Or are you going to be screening when there's now physical signs of change? So this person has now lost weight, their appetite is lower, and that's where you would be using tools like MNA or CNST. So again, shorter tools tend to be favored by our colleagues, often because we're all very busy. So the question really becomes is, have that discussion with your team about what tool do they feel is appropriate. We're going to share with you, though, that we are also involved in a research project across 5 family health teams, and we'll give you a little algorithm of some of the tools we're using and perhaps why, and this may help give you a little bit of framework for your discussions. So as I mentioned, Screen is our 14-item validated tool for seniors living in the community, and it addresses these 14 items. And it gives you a score. Less than 50 would be considered a senior at high risk and would require further nutrition assessment, including assessment for level of malnutrition. Shorter tools, as I mentioned, are the CNST, the Canadian Nutrition Screening Tool, the 2-item tool that's been validated for hospital admission and hospital discharge. This is the one they used in the hospital study. and as well as the MNA, which is the 5-item validated tool for folks with cognitive issues. Irregardless of whatever screening tool you use, the next step means further assessment. We need to figure out in terms of nutrition assessment, but also determining the level of malnutrition. When we look at the literature, what does nutrition support do? Our role as dietitians is to really offer support in this area, both to our teams, help them with their education around detecting malnutrition, but also helping to provide some nutrition advice. As when they come to a dietitian with nutrition counseling, on average we find after about 3 visits, we can see changes and improvements in both functional in a status as well as nutritional status. And nutritional status specifically referring to optimizing intake, correcting the deficiencies, and promoting the weight gain and preventing further loss. But the most important thing we have to do first is use this SGA tool. So subjective global assessment is the gold standard that's been around for many years and was developed by Dr. Gigi Boy. And this is the validated tool that identifies the person's level of malnutrition. So an SGA-A would be a well-nourished senior who would not benefit from additional nutrition therapy from a dietitian. SGA B or C indicates some level of malnutrition. B is mild to moderate malnutrition, and an SGA C score is severe malnutrition. And those 2 categories are populations that would benefit from nutrition counseling from a dietitian, according to the literature. So our RDs have been trained on this, and we recently just had a training session at our AFTO half day where we had about 50 or so dietitians joining us. So we just wanted to share sort of a more comprehensive look at this within our research project that we're launching, hopefully, on December 1st, tomorrow, over the next 6 months. So we've asked 5 family health teams who have a real passion in the area of senior health, would they be interested in participating in this pilot that starts to look at embedding nutrition screening into post-discharge processes, as well as the new interprofessional memory clinic models of care that many of the dietitians and other allied health professionals are now a part of. And the real goal is to identify, can we identify risk, and can we ensure more timely intervention, and does it make a difference? So when we look at the 2 populations, there's a lot of literature out there showing that cognitive functioning is highly affected by nutritional intake, just like physical health is. We know cognitive health is affected by the quality of the diet. And the Mediterranean diet has tremendous research showing the benefit on reducing risk of mild cognitive impairment, reducing the risk of conversion of mild cognitive impairment to Alzheimer's, and reducing the overall risk of Alzheimer's. So these are studies we hope you're all very familiar with or keep in your repertoire of solid evidence. And there's one meta-analysis, there's actually 2 now from this group, Sophie et al. Sophie et al. In 2008 and now this 2013 did an extensive review of, the first study was 1.8 million subjects, this one is now 4 million subjects, looking at using a validated Mediterranean diet score tool. If you can raise someone's score out of 14 by 2 points, you can reduce the risk of overall mortality by 8%, the risk of mortality from cardiovascular disease by 10%, the incidence of cancer by 4%. But the key part here with our seniors with cognitive issues is you can reduce the incidence of Parkinson's and Alzheimer's by 13%. So the Mediterranean diet is definitely a tool we want to be thinking about in this population. So here's the 3 tools we wanted to introduce to you when you're looking at seniors with cognitive issues, is the whole screening piece, screening with the MNA form. Once there's been a positive screen, referral to the dietitian for further assessment and completion of the SGA form to identify what level of malnutrition are we dealing with, as well as using the Mediterranean diet score tool to get a baseline reading of what is this person's Medi-Diet score now, and after 3 visits with the dietitian, what is the change in the Medi-Diet score, as well as the change in the SGA score. And this is a little suggested protocol or algorithm or care pathway that you might want to use that we're using for this research study. Again, it's where someone in the memory clinic team is going to be doing the screening. If there's a positive score of less than 11, then there's a recommendation for a referral to the dietitian, whether that's within that same day visit or a week later. So a referral to the dietitian, whereas a dietitian, you do your normal practice, which is your nutrition assessment, and of course you do weight and BMI anyway. But in addition, we're asking you to assess the subjective global assessment score as well as the MediDiet score. And then if this person is identified with some degree of malnutrition, as in B or C, then you'd want to set up a care plan for them, set goals, and get them back within the next week or two to reassess. And as always, follow-up usually takes 2 or 3 visits. The literature really seems to show 3 visits from the dietitian seems to make significant difference to these measures. And one of the other things we're wanting to be looking at is actually looking at what is the fall rate and hospitalization and transition to long-term care rate in this population as well when we offer service. The important thing to consider in this algorithm, though, this is again not just us as dietitians. We need our team members to be involved with this because many components of malnutrition may or may not be necessarily nutrition related. It could be depression, for example. It could be access to food. So getting our mental health team, getting our pharmacist to help reduce polypharmacy, getting our system navigator to help with food access. There's so many colleagues we have that we really need to bring everyone to the table to really give the best possible care to this patient. Now the discharge, folks. So there is a lot of literature that adding a dietitian to a liaison team after discharge of geriatric patients can actually reduce the number of times hospitalized within 6 months, in addition to helping with nutritional status and functional status, as we've mentioned before. And there was actually a recent systematic review by Monk et al. That you might want to have a peek at because it's quite clearly shows that here is an opportunity for intervention that can really make a difference to outcomes. And in this group, we would be using the CNST score. So this is the tool that's been validated for admission and discharge. So again, if this person is being seen within a week of discharge, it would make sense to use that tool again. And again, we're measuring to see is that validated for use in family practice. Again, a positive on the CNST score means a referral to the dietitian for further assessment using the SGA and a care plan developed if this person is indeed indicated as malnourished. And some of the great things that are happening around the province is we do have some dietitians who have already worked with their teams and have asked the nursing, for many of the groups, the nursing teams are doing the post-discharge phone calls. And so they've embedded these 2 questions into the scripts that the nurses are using. And they're seeing some great success with identifying these folks and getting them linked to the appropriate supports more quickly. And again, here's a little algorithm for you for the post-discharge folks, again using the CNST tool this time for screening. And 2 yes answers to that would indicate a recommendation for a referral to an RD for further assessment, including using SGA. Again, ideally, if this patient's coming in to see someone else in practice, it might be great to link them and do the dietitian visit at the same time. So again, this gives you that nice little flow of a care plan. It might look very different in different settings, but it gives you a little bit of a starting point. So again, as we mentioned, today is to give you resources and tools that you can use in your practice that you can take back to your teams and have those discussions. So we hope that for those of you interested, we want you to let us know at the end of this webinar if you want access to some of our Dropbox folder that has these tools. And this is just a summary. So we can just jump over that slide. And so I'm going to pass it on to Amy and Dennis now, I believe, to introduce some of the custom forms.
I just want to clarify, Dennis, are you able to speak and be heard?
Can you hear me now?
Yes, we can hear you now.
Thank you. Thank you.
Before you jump in, I know we're going to save questions primarily to the very end, but one question has been written in that I think is worth asking now, which is, do you see a possibility of using this tool in a diabetes education program?
Definitely. I think wherever we're doing assessment, we need to be thinking about that person coming in front of us. What are all the nutrition-related issues? Malnutrition is just another nutrition-related issue, and I think this could be used in any clinical process because you're just trying to pick up on those people at risk. So many, as we mentioned, folks that present with comorbidities tend to be the ones who are also presenting with malnutrition. So diabetes clinics would be an obvious point to add this screening tool or one of these screening tools.
And I think anytime you've got a population, a program that you're running that already has some allied health involvement, and you can embed some sort of a flag in that patient's chart that pops up in those situations, because again, if you can engage your team, it's those people that are going to kind of actively activate on a flag and do a screen versus just putting it in, you know, the EMR widespread for everybody over the age of whatever, 65 or 70, it's not going to happen. But if you have an established program where there is some allied health involvement and you're likely to get some uptake in that from this, that's the place I would just start. Start with a specific group of patients that you're already seeing fairly regularly for whatever reason, and build those flags in to do the screens. Anybody else? So is my screen up there, Catherine, with the EMR?
Sorry, let me just make sure. Yes, it is.
Okay. I'm just going to quickly go through one of the tools. These were created for Practice Solutions EMR, but Denis and I are both, you know, they're available. If you've got some sort of other EMR system that you're working with, we would encourage you to take these forms, which again we'll send forward to you, to your IT or your quids people, and ask them to have them recreated in the format that works for your EMR. From the content perspective, though, everything is kind of in there, and we just would encourage you, if you don't use PSS, to try to actively get someone to convert these for you. This is the screening tool that's an encounter assistant called Malnutrition Screening, and this is the tool that's designed for use by other allied health. It could be dietitians, but most often it may be some other allied health in your team, whether it's nursing or social work in terms of memory clinics, or whoever is going to kind of do some of this early screening. So when you import that, it's a form, so you go into your custom forms and import it. It'll populate the person that's actually imported it into the form, their age, their gender. All these boxes are searchable. You can then click on whatever the reason was for the screening, whether it was a hospitalization and there's a discharge, you can enter a date in there. There's no specific format required for that date. You can enter it however you want. And so just tick off what it's for. If it's memory clinic, again, click off memory clinic. Over on the right-hand side, you're just going to click off whether which screening tool you've chosen to use, whether it's CNST or the Screen 2. If you pick the CNST, what happens is you get this little box, and then you can click off whether it's the first time you're doing this or whether it's a rescreen within that month window. So when you click initial screening, up pops the actual screen itself. Those questions are embedded right in the form. And the two questions are, have you lost weight in the last 6 months without trying? And have you been eating less than usual for more than a week? It's only positive if those both questions are a yes. So in that situation, if you're clicking both a yes, you're going to do a 2. That's their score. And then you're going to click off this box, refer to RD. And once you do that, and also click some little notes in here if you've got some commentary. Whoever's doing the screening wants to make sure you're aware of something in specific. When you hit finish on this box, what will happen is that an automatic reminder will go to, I'll show you. So you can now see there's a reminder. It's going to myself in this case for that the CNST was completed and they're at nutritional risk. When you embed these in your own EMRs, you're going to get your IT person, if you're not able to do this yourself, get them to format that piece of where the reminder message is actually going to so that it gets directed to the right person. And then you're going to kind of go back and have a look at that, call them in, whatever your process is for getting them in to see them in that visit. Okay. I'm just going to go back and do this again to show you something else. Malnutrition. So now we're in here again. If I was to pick the Screen 2, what happens with this one is you're going to actually click on this Screen 2 icon, and the actual screen questionnaire pops into your EMR as a separate note. You have to manually go through. This is the abbreviated version, so there are actually only 8 questions. So it might be something that's a little more palatable than the full version if you're having someone else do the screening for you. You manually will go through and click off the scores, and then you're going to add them up yourself. I'm trying to make this math easy for myself. Okay. So then you've done this questionnaire, it's in there. You need to manually do the addition. We haven't been able to make that a simpler step for us yet, but might come. 8, 10, 12, 20, 2, 4, 32. So you zip up to your form. You're going to put a 34 in there. And we've got the little Q built in there. If it's less than 38, they are at nutritional risk and should be referred to dietitian. So again, when you click this refer to dietitian box and hit finish at the end, you'll get that automatic messaging popping up again for yourself. Is that pretty? Anything else, Dennis, that you'd want me to make sure I touch on there?
What I would like to add on to this form is the date of discharge. It cannot be any of the format, but it might be a glitch in your custom form in your encounter system that you don't have to type a specific format, but I will show the audience what I have in my form in terms of entering a date. And thank you, Amy,
that would be helpful.
Pointing,
yep.
Yeah. And thank you, Amy, for pointing out that when you have this encounter assistant installed in your system, you need to get in touch with the IT person, or you might have to tweak a little bit behind the background of this encounter assistant to make use of the referral message or the reminder message. Because by default, it is the current user sending to the current user. But in fact, in your clinic, it might be a NP screening or might be a nurse screening to be sent to a dietitian. So you do have the option to tweak it around to decide who to send a message to, but it has to happen after it is installed into your EMR server.
Thanks, Ed. And the other piece to this, I was just going to remind people too, when you're uploading these forms, in order to have them work with the underlying programming that's there, you also have to upload the screen form and the CNST form. So those are two other separate forms that have to be loaded on your EMR in order for this functionality to work when you put the screening form on.
And for those who have access to our Dropbox for the Primary Healthcare Action Group, all these tools, including the Encounter Assistant, the custom form of Screen 2, the custom form of M&A, and the custom form of CNST, are all available in the Dropbox folder for you to download. If you are interested in gaining access to the Dropbox folder, feel free to send us an email. Either Michelle or myself will be able to gain you access to the Dropbox folder.
And you can just see on my screen, once you've hit finish, I've got 3 forms in a row because I just did it 3 times today. The whole form collapses into a pretty short little note from malnutrition down to this, which is a summary note text, and that's what actually will show up. And underneath will be whether or not you've put in the CNST or the Screen 2 form will also show up as a separate note with the message. Okay, Dennis, do you want to take it away?
I will share my screen and walk you all, ladies and gentlemen, through the second form that we have for RD to work. So keep that in mind. This screening form is not ideally to be used by dietitian. So if you have someone in the clinic who can do the screening part, that would be great. If not, then probably you have to be the one to take up this task. Amy and Michelle, would you be able to see my screen?
Yes.
Yes, I just can now.
Okay, sounds good. So this is another encounter assistant developed for this malnutrition initiative. The top section over here is called Clinical Interaction Demographics, with the appointment date, which is by default to be populated as today's date, and registered dietitian, whoever the current user is opening up this form, the name would get populated into this field. And ideally, this is not a screening part that you have to do, but if you are that unfortunate in your team or that patient, you have not have any screening activity done, you can do CNST screening not done. Then the 2 questions will pop up. The date of initial screening, you can type it in, checking off yes or no. Remember, there's a brief note over here about a score of what you need to refer and what to do. If there's a score of 2, complete the SGA form because you are the dietitian, so you don't need to refer to another dietitian or maybe another colleague who is specializing in malnutrition, then you can do that referral. If that is a score of 1, then you have to rescreen in 1 month. This is a little bit different from the original CNST questionnaire. Rescreening within 1 week is only applicable to the acute care setting. So in a community primary care setting, Dr. Hattie Keller has advised us to rescreen in 1 month. A score equal to 0, indicating that the patient is not at nutritional risk and no further action is required. If you are doing a screen 2 screening, CNST is designed for the post-discharge. If you're doing anybody in the community or maybe a memory clinic, then you can do screen 2 screening and scroll down to a section which we call screen 2 screening. You can enter the score, but if you want to see the questionnaire and do the scoring before you enter the score, you can click Insert Screen 2 AB, stand for Abbreviation Questionnaire. And this questionnaire will pop up underneath of your encounter assistant. After you fill this out, the 8-question questionnaire, then you can either type the score in here, or you can do the score over here, or if you prefer, you can do both places. It's just a bit, we'll have a bit advantage in doing data analysis or data management if you enter the score into both places. Ideally, the screening part has been done. A patient being referred to a dietitian now needs an assessment to be done. If you're doing assessment, you can click on the assessment, and on the right-hand side, you will see the wait time, which is only to be filled out at your first appointment. And it's number of days between the referral date and the first RD appointment date. It could be the same day, could be the next day, could be in a range of 2 to 7 days, in a range of 8 to 14 days, in a range of 15 to 21 days, or 21 days or above. As Michelle has suggested, this is assessment after the screening process. We would do the SGA tool and try to assess what kind of rating the patient is getting, whether it's A, B, or C. So insert the SGA custom form. It is exactly the same as the PDF version getting from the Canadian Malnutrition Task Force website. You go through each of these questions with the patient, try to do the check boxes, and enter additional information as you go along. Physical examination. And the last part over here is the SGA rating. Using your clinical judgment and the data that you collected on this SGA assessment form, you'll be able to identify whether it's A, well-nourished, B, mildly, moderately malnourished, or C, severely malnourished. Let's say this is a patient with rating B, and it will check up this box. And you also have to go back to the encounter assistant and check up the box of B over here. To facilitate your assessment, we'll also have the weight changes information section over here. One of the very important parameters that we have to look at is the weight changes, especially unintentional weight changes. The reason why I have the weight colon over here is if you don't have the weight colon over here, the number that you enter after this box, it won't get populated into the graph. So it just makes it easier for you if you want to see the graph. Oops. So this is a 30 that I entered just now. If you don't have the weight, for some reason the 30 is not showing up here, but don't worry about this. This is for your working copy. What we care and what we need to collect the data from this encounter assistant would be the percentage of weight change. Sometimes it's not possible for you to have assessment of the 6-month weight changes because the patient don't even remember how much they were weighed 6 months ago. Or if this is a new patient being referred to you, have no history with this family health team or family doctor, you might not have a good objective information on the weight. On the bottom right-hand corner over here, we have a section for labs. And after discussion with the primary healthcare action group and some expert in malnutrition, we decided that albumin hemoglobin, hematocrit, ferritin, and vitamin B12 would be the 5 biochemical parameters that we would like to have access to while we are trying to do the assessment of malnutrition. Here is a field that you can type in what type of supplement that the patient is on, if their B12 is low, and it makes sense that you want to see if they are on a B12 supplement. If not, whether this is a recommendation that you will go with. Another scenario could be ferritin is being low. 23 is a good number, but if you see someone is on an 8 or in a 7 range, then you might recommend a ferritin or any iron supplementation that is suiting their need to bring back up and to correct the deficiency. Assessment summary, as you would use this form for your charting, then you can type it in, and this field is expendable. I don't know why my keyboard is not working out well, but I try not to type so that I don't get any more error messages. So this is assessment summary. As you type, it will be expanding downwards. As we have been mentioning about IDNT or the ENCPT, we would like to capture what is a nutrition diagnosis for this patient to be considered as malnourished. Whether it's about inadequate protein intake, it's about inadequate energy intake, inadequate fiber intake, vitamin intake, or mineral intake, or in general as a poor nutrition quality of life. If these 6 are not fitting into what your assessment is suggesting, you can feel free to check on the box of other, and you can specify a diagnosis that would match with your assessment the best before you click on finish. As the same as a screening tool, you will have an option to send yourself a private message as a reminder. Maybe you need to follow up with the referral process. If you refer it to RN to follow up, if you refer to a geriatrician for follow-up, then you also want to remind yourself of what you have done today. The last section over here is internal referral and external referral. We have been talking about care coordination in primary care. At one family health team or with one dietitian, we might not be able to contribute to the best or maximize the care or quality that we deliver. And oftentimes, we might have to bring in another discipline or another professional into the care of this patient, which is the health link model. Maybe with a medical specialist, social worker to be involved in some stress management or welfare or any other system navigation in your neighborhood, in your region. This patient might require some of the OT or PT support to avoid having any muscle atrophy or to correct their functional loss. External referral, you can refer to HealthLink. If not HealthLink, you can also refer to some hospital-based program, such as a CKD clinic located in a hospital, a pre-dialysis, or a community-based program could be just an exercise program at a community center, or maybe it's an exercise program at a Y that you have partnership with. What I wanted to show you in this tool, and it's a highlight. Remember that we check off the SGA rating over here, A, B, or C. Upon the click of a finish, the diagnostic coding of 263 has been added to the patient's CPP. And being labeled as B, mildly and moderately malnourished with some progressive nutritional loss. With this diagnostic coding attached to this description in a problem list or in anywhere in a CPP is trackable, is extractable, and we can analyze the data afterwards to assess how many patients is diagnosed with a level B of malnutrition or level C or level A. Since we are doing the screening part and the assessment part, it is important for us to capture information to evaluate the effectiveness and the efficiency of our program. For example, the total population, total number of patients that you screened, how many of them has a positive result? Let's say SGA rating of B and C. And this chunk over here is just the collapsed format of the Encounter Assistant that we just used with a diagnostic code of 263 attached to it. At the same time, you are also developing a registry for your patient who are diagnosed to be malnourished in your EMR system. make it easier for you to do the recall system, and make it easier for you to communicate or have a case round, have a weekly round or grand round with your team, to tweak the program a little bit and to streamline your program to improve the effectiveness and efficiency in your family health team.
So Dennis, on that note, do we want to move to outcomes, which you've just nicely segued into?
Sure.
So as Dennis mentioned,
any questions, Michelle, sorry, about the forms themselves that have come up, or everybody's good with that?
Do you want a slide to be on, Michelle?
Sure. Any questions coming up about the forms?
Sorry, I had my phone muted and I was trying to talk. Yes, there's one question asking if there is a custom form for the MNA.
That was my question I was going to mention to Dennis. We recently had a meeting with Dr. Linda Lee, who is spearheading all of the memory clinics around the province. And as dietitians, we've been invited to this model, this interprofessional model, which is great news. But in our discussions we've had with Dr. Linda Lee, she felt that the MNA SF form would be the better screening tool to start with because it's a bit shorter and it's clinician administered. As dietitians, we tend to favor Screen 2 because it's sort of more upstream and is showing changes in eating behaviors. But we thought this would be a good idea just to get screening started. So that would be one of our next steps for Dennis and Amy, our EMR experts, would be to try to actually get MNA part of the memory clinic protocol. So on these custom forms that they've just introduced to you, that would be the next step to get that added in. Next year, we'll have the opportunity to meet with Dr. Linda Lee and other groups and actually then have further conversation about how did screening go and do we want to consider changing the tool to a little bit larger tool.
And based on a discussion with Dr. Linda Lee, Heather Keller, and our Primary Healthcare Action Group folks, we decided that the post-discharge population will stick with the CNST. And for the memory clinic who are involved in the demonstration project will use MNA. But we do recommend that everybody else in the community, in the primary care, to use Screen 2 and CNST as the two major tools for the screening. MNA at this moment is strictly for memory clinic involved in the project. Am I correct, Michelle?
You're right.
Sorry, the only caveat I would add to that is when you're considering which one to use is that the MNA needs to be clinician administered. So if there is a sense within your teams that you want to use something that the patient or patient's family can do themselves while they're waiting, you would want to be using one of those other two tools.
Screen 2, yes. So MNA, some folks might want to use the MNA, so that's where if we do the work, Dennis and Amy do the work of adding it to the custom form for our research project, that is something we could share with others if that's the tool that you have chosen to use. All right, do we want to go to the outcome slide just to wrap up and then give a few more minutes for questions? So Dennis had mentioned this already, but really what we want to be able to look at is a year from now, we want to be able to look at this population and say, how many referrals did we get with a code of 263? So these are seniors referred for some issue around nutritional status. Of those people referred to us, how many were screened positive? So how many have nutritional risk? Of those with risk, how many actually go on to have an SGA score of B or C, which shows some degree of malnutrition? So we would like to be able to say, in my clinic of 2,000 seniors, what % actually are appearing malnourished? Are those malnourished seniors coming to see me as a dietitian for further assessment, or are they not? Because that sometimes there's some barriers around that for them. And once they see us, does our nutrition intervention, like the literature predicts it does it make a difference in things like their weight, BMI? Can we change this SGA score from a severely malnourished senior with an SGA C, can we switch them to an SGA A? And does what we offer actually make a difference on future hospitalization and falls? So really looking at chart reviews 3-6 months down the road to see, like the literature shows, can we actually prevent some of these falls and readmissions? that are associated with seniors that are malnourished. So we have a little Excel spreadsheet we can share with many of you that will be looking at these pre-post scores of the intervention, and again we'll be doing that in our research project, but these are tools again we are happy to share with others who may want to be doing it across their settings as well. Our research project is going to be the next 5 or 6 months, so we might want to test them out for you first and then give you a report on how well they work, because the questions we're really looking at is, you know, what % of our seniors are identified at risk and are identified as malnourished? What % of those seniors access our service? Does our intervention and team-based care make improvements? Did our teams adopt the screening recommendations and work together in a collaborative model of care? Is this a feasible model worth spreading to other teams across Ontario and in their FITs and CHCs? And which specific nutrition screening tools seem to be the best to use in primary care? So there's many questions that we're trying to answer with our demonstration project, as well as getting all of you thinking about starting screening across the province. So did we go ahead, I was going to say, did we want to open up to questions?
Sorry, just one more comment before we open up for the question Q&A sessions. To give all of you a heads up that we are in the middle of a discussion of how we can collect data across the province, not just for the 5 demonstration, not the 5 sites involved in the demonstration project, but if any of a dietitian, whether it's in family health team or CHC, you were actively screening for malnutrition population and you were assessing, intervening this patient population, you're more than welcome to submit data to the Primary Healthcare Action Group. And we are still trying to plan it out how it can be more efficient and effective in terms of submitting data to assess the effectiveness of our program. But given the limitation in the EMR, it's only cross-sectional evaluation can be done. But if we are doing pre and post, let's say the weight or pre and post SGA score and pre and post Mediterranean diet score, it is considered as a longitudinal analysis that we need some more manual work, maybe creating a spreadsheet for having an initial baseline data, and then every 6 months that a team of dietitians or any of the dietitians who have a passion in research, you can update, you can refresh the data from an EMR and capture it down onto a spreadsheet. Then we'll work on the next step, how to submit these data to make a valuable appreciation in an aggregated aspect.
Okay, great. All right, do we have any questions from anyone?
We have 2 questions that have come in. They're both kind of follow-ups to questions that were asked earlier. So first of all, as a follow-up to the one about using this form in a diabetes program, could the assessment, it says, could I add this assessment question to a diabetes intake form? Definitely.
The 2 screening questions of unintentional weight loss and low appetite? Yes, you can embed that in any of your assessment tools. I mean, and in fact, when you think about it, all of us assess that as dietitians, but so do our colleagues, but just perhaps not in a structured way that show 2 yes responses indicates need for further nutrition assessment. Because when I speak to my nursing teams and I'm listening to nursing and pharmacy and OT, everyone asks about weight. Sometimes unintentional weight loss is not asked specifically, but they are assessing already to some degree. I think we just need to give them this framework of here's the 2 specific validated questions that we would like people to be adding to any of their assessment tools.
Great, thank you. And the other one is, I think, coming back to the question about custom form for the MNA. So this is somebody else asking, what about using, and I'm sorry, I don't know what all these acronyms mean, but what about using CNST in memory clinic? This was preferred by the NP when I approached her over the MNA because it is shortest.
Right. So this is what the conversations you'll have, and we've had many of them. So it really is a question of, as the Primary Healthcare Action Group, our goal is to get you screening. So if it takes a short tool to get your teams starting to look at this population, great. It's a great start. It is downstream, right? You now have physical change at that point, but it's a start. So I would advocate to, you know, have that discussion, get something started. You can always tweak things later if you feel that screen 2 is actually more appropriate, but, you know, give it a trial run and see what your team members think, and then slowly nudge them towards using perhaps maybe the more appropriate tool for that population, depending on which population you're looking at.
The next question that's come in is a more clinical one. So it has to do with the Mediterranean diet, asking about cognitive impairment. So if Alzheimer's, for example, is already present, does the Mediterranean diet help prevent or delay further progression? Just curious because evidence seems to be more related to prevention.
Yeah, so there is a lot of literature showing prevention or delay from MCI to Alzheimer's, but there does seem to be some evidence also with the Alzheimer's population, whether you can delay decline. So there's a little bit of literature on that as well, or slow down the rate of decline. I didn't put that in the slides because most of the folks in our memory clinics are folks presenting, at least with the people I've talked with, are presenting more with MCI, so mild cognitive impairment. Some people are presenting and they haven't even been diagnosed yet. Other people may be experiencing seniors with quite advanced Alzheimer's. In that case, too, as a dietitian, we have a lot we can contribute to just helping prevent malnutrition. We know malnutrition in general is poor prediction for poor health outcomes. So whether this person has Alzheimer's or not, we want to help this person, you know, get the nutrients they need and stay as healthy as possible for them.
Thank you. I don't see any other questions in yet, so just a reminder to everybody, there is a questions pane or panel on the right-hand side of your screen in the control pane, and there is also a raise hand function. If you'd rather ask your question out loud, you can raise your hand and we will unmute you and call on you.
It's a lot of information, that's for sure, in one hour webinar. But we are looking forward to communicating with other people to find out what you might be doing in your practice, what you might be starting around this population. So if there are things you want to share, feel free to contact myself or Dennis or Amy, because we would like to sort of keep our finger on the pulse of what's actually happening around Ontario and seeing what type of initiatives are starting.
Thank you, and I'm just going to put all of your email addresses into the chat pane for everyone.
You've got me thinking. We've got the Medi Diet form embedded in another project that we've been working on, the metabolic and diabetes piece. That just got me thinking that, Dennis, I'm wondering if we should have it in here too as part of your assessment. Anyway, something else to think about.
We do have the Medi Diet score custom form go live. And if you want a copy of that custom form, feel free to email me and I can share that with everybody.
But it may be something to link with our memory clinic custom forms because it shows such strong literature, and it is a score where we can show significant change, often pre-post intervention. So that may be something.
So just embedding it right in that tracking form that we were just reviewing might be useful.
Of course, definitely.
Okay, Dennis.
Any other questions?
Nothing else has come in.
Okay. So we'd like to thank everyone for taking time out of their lunch hour and spending time with us and thinking about this population. We would love to hear more from you in terms of what you're doing or how we can offer some support, whether that's resources or infographics or even just links to some of the literature and evidence that's out there. And we're here to help get you started with this. So please feel free to contact us and email or chat on the phone if you'd like more information, and we'd be happy to help point you in the right direction with some of the tools that we've started to use. Amy and Dennis, you want to say any last words?
Thank you everybody for joining us over your lunch hour, and we are open for any questions or any troubleshooting steps, and we're just an email away.
And I agree with everybody. I think it's just take a baby step. We've been immersed in this for so long, and I still find it still new. You know, you kind of have to be thinking about it all the time, but if there's one little systematic thing that you can do to embed this in one small group of people that you are connected with or your team is in a specific program, just start doing one little thing. And it's just the repetition of doing it kind of builds it into your everyday practice.
And I just want to mention to you, this is very timely because the ministry is quite interested in senior health, and we're actually in the middle of planning an RD MPP day for March 1st at Queen's Park, where we're going to be focusing on malnutrition across the spectrum of nutrition care, from hospital to home care to family practice to long-term care. So it's a very timely issue. There's a lot of interest, and I think we have a real opportunity to really lead the charge and spearhead some innovative changes in our practice to really help detect risk in this vulnerable population. So good luck, everyone.
Bye for now.
Bye-bye.
Bye. Thank you, everybody.